All right. Everyone's had a great break there. All right, today we're going to be talking about Section J. And so the purpose of this section, or the objectives today, are to illustrate a working knowledge of Section J, which is falls, and other health conditions, and to articulate the intent of that. So hopefully by the end you'll have an understanding to be able to interpret the coding options and apply the coding instructions in order to accurately code and be able to complete our practice scenarios. So all items in Section J are new for your setting. So we have J1750, which is history of falls, and that is completed on your admission assessment. We have J1800, any falls since admission, and that makes sense. That's done on discharge, right? So we're looking at the whole time that you're in your facility. J1900, number of falls since admission. So that makes sense again. It's only done on discharge. And then J2000, prior surgery, which is captured on the admission assessment. So the intent for Section J is to code the history of falls and any falls since admission, including any injury caused by the falls. And we're going to go through the details of those as we go through this section today. So let's talk about a definition of a fall. And this applies in our manual here. Unintentional change in position and coming to rest on the ground, floor, or onto the next lower surface. It may be witnessed, reported by the patient, or observed, or identified when a patient is found on the floor or on the ground. So, and this includes the intercepted fall, and we're going to talk a little bit about the intercepted fall as we move on. The one thing to remember about falls is it's not a result of overwhelming external forces. So if we have someone who falls because for some reason they were pushed, or, well, you know, these items come from the nursing home, and sometimes they don't play nice in the nursing homes, and one person may push another, they get frustrated, but if they get pushed by another patient or knocked over by a piece of equipment, so it wasn't, that wouldn't be considered a fall. An intercepted fall is considered a fall, and again, we're going to talk a little bit about that. An intercepted fall occurs when the patient would have fallen if he or she had not caught him or herself, or they had not been intercepted by another person. This is considered still a fall, but it's called an intercepted fall. So let's go through, and we're going to get some examples here. So the history of falls. So why is this important? Falls are the leading cause of morbidity and mortality. The most important predictor of risk for future falls and injurious falls include, the one most important one is previous falls, right? I mean, so if someone has a history of falling, they're already kind of considered at high risk. So previous falls, certainly a recent fall, or falls with significant injury. And persons with a history of falling may limit activities because of the fear of falling and should be evaluated for any reversible cause of the falling. So, and I think we see that certainly in our older population, if they've had a fall, they're going to be very, very careful and may not be as willing to try things because they're afraid of falling. All right, so steps for the assessment indicate if the patient has had 2 or more falls in the past year and or any fall with injury in the past year. So remember, this is done on admission, so we're looking for history of the falls. You want to talk to the patient if capable or reliable, and so can they give you the information about their fall history? Or speak with family members, caregivers, those people who know your patient, who could give you some of that history. So in question J1750, we're going to complete this at the time of admission, and we're asking the question around history of falls. Has the patient had 2 or more falls in the past year, and or any falls with injury in the past year? So we're looking for 2 or more falls. You'd code that then as yes. Or they could have had 1 fall with injury. and then you still would code that as yes. So let's start with a practice scenario. So Mrs. T reports that she fell 3 months ago, and then again 1 month ago while walking outside. This is on the admission assessment. Mrs. T stated she only bruised her arm during the first fall and then her knee in the second fall. She reported she didn't need to seek any medical advice. She was able to recover without any apparent injury, and she was not too concerned about her falls. So if this was your patient, how would you code J1750? So if you take your polling devices, and if we can code this. Okay. So most people got this correct. The answer here would be we would code yes. And the reason for that is that the patient had reported 2 falls, right? They had 2 falls. And so it was pretty clear there. She said, I had a fall at this time and this time. I didn't have any major injury with the fall. Okay, let's look at another scenario. Mr. W was unable to provide information on his fall history, but his wife was. She was able to provide the information. She stated her husband fell 8 months ago at home outside in their driveway. He hit his head and needed 7 sutures to his scalp. This was the only fall that he had in the past year. So now, this is a new patient. How would you code this patient in J1750? So again, if you use your devices. All right. So most of you got this correct. Some people put 0, code no, but let's talk about this. The actual answer is code 1, yes. And we're going to talk about why we would code that. So we're coding yes because Mr. W only had that 1 fall, but remember it's 2 falls in the past year or 1 fall with a history of injury. So the fact that he had the fall in the driveway, needed to have sutures, allowed this to be scored as having 1 yes. All right. Any questions on that? Does everyone? Most people, I think, got that question. Okay. So J1800, this is any falls since admission. So since we're looking at the point of admission, we are going to be assessing this at discharge. Right, we're going to assess this. So this is a discharge assessment item. So we already talked about this, that falls are the leading cause of morbidity and mortality. The fear of falling can limit an individual's activity and negatively impact their quality of life. And certainly in your particular care setting, this would be something that would be really important for your patients to have confidence in being able to ambulate and not have a fear of falling. So our steps for assessment, we're going to review the inpatient rehab facility medical record. You can maybe look at physician notes, nurse practitioner notes, nursing notes, therapy notes, nursing assistant notes, maybe have incident reports, some sort of a database or a fall log, whatever it is that you use, or a combination of things that you use in your organization, which are going to help you to be able to code this particular item to find out if if it was my discharge, have I had any falls? And so in J1800, the coding instructions, we're only going to complete it at the time of discharge. And note that what we're looking at here is, has the patient had any falls since admission? So it's a yes or no question. They either had falls or they didn't have falls. So let's do a quick practice scenario here. An incident report describes an event in which Mr. S was walking down the hall and appeared to slip on a wet spot on the floor. He lost his balance and bumped into the wall, was able to grab onto the handrails and steady himself, so he never landed to the floor. So let's say this is your patient. How would you code J1800? Has the patient had any falls since admission? So you can discuss it at your table if you want, and then use your devices. Okay, so that one caused a little discussion. So that's great. That's how we learn, right? It's when we have open discussion to try to figure this out. Has the patient had any falls since admission? Well, 87% of you answered B, yes, and 13% said no. In fact, the answer is yes. And why would that be? An intercepted fall. Exactly. Any fall since admission would be coded as yes. An intercepted fall is considered a fall. So even though the patient didn't end up on the floor, if they hadn't had the wall there and the grab rail and the ability to grab onto it, they would have ended up on the floor. So that's considered an intercepted fall. All right. So this is that's a new concept for you. So it's probably an area when you're thinking about your action plans. There's still a lot of buzz here. All right, so let's pull it back together. Is there a question about that particular situation that's causing a lot of discussion? Do you guys seem to understand? Can you think about how you're going to explain this when you go back to your facilities? How you're going to train your staff around this? You may want to think about also for this intercepted fall, how do you capture that? Is that something that you capture today? Okay, so it's maybe not something that you don't capture today, but how are you going to capture that? Where are you going to capture that? How are you going to gather that information so this is something new that you're adding to what you're doing. So there's lots of little pieces when you go back to your facilities that you got to stop and say, how is this going to work? Yes? I don't know. I think they're turning them on. Okay. No? Okay, so the question is this, in case you didn't hear it. If this data was captured in an incident report, and the incident report is not part of the medical record, and that's probably true in everyone's setting, right? We don't put incident reports in the medical record. Can we still query that incident report to capture this information? Absolutely yes, you can. Okay, so it could be a log, it could be your incident report, it could be some other database that you keep to be able to query that information. I would also think that you might find something somewhere in a nursing note, or somewhere else that said this happened, because what all of a sudden, if that person ended up having bruising, like the next day, you might want to say, oh, well, they had this thing and they whacked their arm on the rail as they were grabbing it, and now we got a bruise across the arm and we know how that injury happened. We have another question over here? It should be on. Oh, no, you're testing the... Are you sure you don't have a question? One of our techs there. We have a question over here. Hold this way. Yeah.
Yes, I have a question. I know when physical therapy and occupational therapy are working with patients and they have to give them steadying assistance because they might have a little difficulty staying straight. If they start to fall and the physical therapist has the gait belt and they prevent them from falling, does that count as an intercepted fall?
I knew this question was coming. And you're going to get frustrated with me, and I'm sorry about that. We had this discussion, and we just needed to go. We have a tentative answer that I'm not going to give you today because I don't want to give you an answer today and have it changed tomorrow. We will get this answer explicitly out to you in the very near future. These items, believe it or not, have been in the MDS since 2010, and that question never came up. No. So we are looking at this and making sure, again, the idea, and I hopefully you don't get frustrated with this, sometimes we don't give you an answer because we have to look at it across the setting, all the settings, and making sure that we have consistent answers that are happening. So we will get that information back to you. But our subject matter experts, Gina and Karen, brought that exact scenario to us and saying this is a question that's going to come up.
I have some concerns about how this is going to affect our hospital stats for falls. These are really not falls, and it's going to wreck our stats.
So when we look at the falls and the intercepted falls, so I see, is that Terry? Terry Mata from CMS wants to make a comment on this. Thank you, Terry.
So I heard some folks talking about, well, it's because it's a nursing home, that's why you're considering it a fall, and that's not true. So one of the things that I did want to let folks know is that survey and certification for nursing facilities is a big deal. We have surveyors in our facilities all the time, and this is how they define falls. So we need to use the definition that the surveyors give us for falls, and that's why it's in there. So, but going back to what Ann said, we are going to go back and look at it and provide an updated answer.
Right. Specifically around like the therapy and the having the gait belt and looking at it as a therapeutic intervention as the fall. But in this situation, though, if someone's ambulating along and they, kind of go into the wall and grab the rail, for right now, that is in the manual, and that actually would be an intercepted fall. When we're looking at the scoring of the falls, how many falls, it's 2 or more falls. So if they could have 10 falls or they could have 2 falls, it's just, 2 or more falls. And we'll get into that question as we move forward. But thank you for those comments. Certainly we'll take those into consideration. As you know, we take all of this information, bring it back, and we have a whole team that looks at it, and we look at it across care settings also. All right, so according to the therapy notes, let's look at another scenario here. According to therapy notes, Mrs. J was walking using parallel bars when she became weak and was assisted to the floor by the therapist. Okay, so here's someone who's assisted to the floor. How would you code this assessment here? Okay, so in this scenario, everyone got this one correct, and it was very clear, right? Because they went to, they were assisted to what? To the lower level, and that is consistent with everything you do. I have a question over here.
How would we differentiate an intercepted fall from a loss of balance? It seems like that could be very subjective.
Yeah, I think what I heard about the therapy question is kind of that, if someone's listing to a side because of a stroke or whatnot, and we're helping them to allow them to understand where their body is going and how to right themselves, and they've got a gait belt and whatnot, that's the question that we're going to get some clarity to you. So hopefully once we come up with a definition and some examples around that would be clear for everyone. Yes?
What if the patient self-corrects?
So they're ambulating and they self-correct, okay, themselves, without falling. Again, I think it goes the same thing, but the fact that the patient did it themselves, I mean, if they ran into the wall and then self-corrected, that would be, a different thing. I think, generally the intent of this is that they had kind of an unexpected thing that they went in and they're kind of grabbing, and if they hadn't grabbed the wall or they hadn't grabbed that handrail or someone else hadn't grabbed them and prevented that fall or eased them to the floor, it would be a fall. But hopefully all of these subtleties, and there's a lot of therapists here, and so I did kind of anticipate that we would have these questions, and I need you to be patient with us to be able to get that information back to you. We tried really hard to have an answer before today. It just, we didn't have the clarity for it. Okay, so we had this one. Everyone is very clear. We went to a different level, and so we considered that an intercepted fall because a staff member assisted them, but they still ended up, going to a lower level there. All right, so J1900 is number of falls since admission. So we can look at the medical record again, physician, therapy notes, incident logs, fall logs, whatever that you have, databases that you have in your organization. So injury related to fall. Any documented injury that occurred as a result of or was recognized within a short period of time, for example, hours or within a few days after the fall, or for the fact it was attributed to the fall, would be considered the injury. So I kind of gave that example a little bit before about that intercepted fall where that person kind of fell into the wall and whacked maybe their arm on the rail that maybe 24 hours later now they had a bruise. And you could say, oh, well that, they whacked their arm, it was a little red, it wasn't bruised right away. Here within 24 hours now we have a bruise. We know that that bruise, more likely than not, was directly attributed to that fall, or that intercepted fall. So let's look at the coding instructions for this area. Complete at the time of discharge. So again, this is from admissions to discharge. Determine the number of falls that occurred since admission, and then code each of the falls only once. So for example, if the patient had multiple injuries in a single fall, code the fall at the highest level of injuries. So if they ended up with a scrape, a bruise, and a fractured finger, the highest injury would be the fracture, okay? And so we're only counting that, coding that as once. So coding instructions, code 0, none if the patient had no injurious falls since admission. So this is again looking at injury. Code 1, 1 if the patient had 1 non-injurious fall since admission. And code 2, 2 or more if the patient had 2 or more non-injurious falls. So no injury, no evidence of an injury is noted on the physical assessment by the nurse or the primary care clinician. No complaints of pain or injury by the patient, no change in the patient's behavior. So they had the fall and nothing changed. They're fine. Okay, those are non-injurious falls. And so you'll look at the maximum number that you have here is coding 2, 2 or more. So they could have had 2, 3, 10, 15, 20. It didn't matter. You're going to just code you would code that at a 2. Okay. Let me go back one, I'm sorry, here. So in 19B, coding instructions, so if the patient had injury except for major, so you have 3 questions here. The first question is 1900A, which says we had no injury. The second question said we had an injury, except for it wasn't a major injury. So we're going to talk about what is an injury and what's a major injury and what's the difference between them. So injury except for major, and it includes, and this is not an all-inclusive list. These are examples of some things that might be considered an injury but not a major injury. So a skin tear, an abrasion, a laceration, a superficial bruise, a hematoma, a sprain. So any fall-related injury that causes the patient to complain of pain may be considered an injury, even if there's no obvious, bruising or whatnot. So again, I just need you to know that this is not an all-inclusive list. These are just examples. So you need to make that determination. So the one here that gets sometimes has people concerned is the idea that we have a laceration. So is it a small laceration, something that we can put steri strips on, or is this a major laceration? They have to go to the emergency department and have sutures, okay? Kind of have to weigh that out. So then we have the third question within this series of questions, J1900C, which what we're looking for here is major injury. So no injury, kind of minor injury, and then major injury. So those are the 3 questions, and they're asking for the number of falls for each one. So what are some examples of some major injuries? Bone fractures, joint dislocations, closed head injuries with altered consciousness, subdural hematomas. They're giving you pretty significant things here. But this hopefully gives you an example. If they had a laceration, complex laceration that needed sutures and an ER evaluation, may in fact be coded as a major injury. All right, so let's look at a coding scenario. So a nursing note states that Mrs. K slipped out of her wheelchair onto the floor during a transfer from the bed to the wheelchair. Before being assisted back to her bed, an assessment was completed that indicated that there were no obvious injuries. So now this is our discharge assessment. So this is from admission. How would you code J1900? So you have 3 things that you need to code in this section. You need to code no injury, injury, and major injury. And the coding that you have for that are none, 1, 2, or more. You have it in your head how you would code that? Okay. So how we would code this J1900A, no injury would be coded as 1. So did they have any kind of injury? Minor injury, so we would put a 0, right? They didn't have any. And then how about major injury? No, 0. So you would see the coding there is they had a fall with no injuries, and they only had 1. All right, let's look at another coding scenario. A nursing note describes a patient who climbed over his rails and fell onto the floor. On examination, he had a cut over his left eye and some swelling of his arm. He was sent to the emergency department where an x-ray revealed no injury. Neurology assessed the patient and revealed no change in mental status. The patient returned to the IRF within 24 hours. So let's look at that coding scenario. So again, these are the same coding questions. We're looking at no injury, minor injury, and major injury. So let's give it a second. I'll let you think about how you would answer those questions. All right, so again, we're going to answer the 3 questions. So let's look at how we answered the question. So we answered J, 1900B, injury, except for major, would be coded. So let's say they only had that 1 fall. They had a fall, but it had some sort of injury, so the no injury would be a 0, right? No other falls for that. Here we said B would be they had injury. They had a suture or 2 when they were in the emergency room. And then here wouldn't be coded as a major injury. They didn't end up with a subdural. They didn't end up having to have an extended hospital stay and complications due to that fall. Is that clear to everyone? Okay. So here we get a little bit more information. A head CT scan revealed. Okay, I'm sorry. Here's a third patient. So a patient fell, lacerated her head, and was sent to the emergency department. A head CT revealed a subdural hematoma, and the patient received treatment and returned to the IRF after 2 days. I think that's pretty quick for a subdural, but that's great. Okay, so we're doing drive-through, but so they did well. Maybe it was a teeny subdural, and they did very well, and whatnot. Okay, so this is your patient. They fell. They went to the emergency room. They had this CT, had this subdural, and they now return back to you. Now you're doing your discharge assessment. How are you going to code this patient? 001. Very good. You got this down pat. Okay. So here in this situation, they had only that 1 fall. Now, what if they had had a combination of fall with no injury and then a week later this fall with a subdural? Right. 101. So you would have captured those. Okay. So you get the idea here. So it's categorical, looking at each one of those questions with the total from admission to discharge if they've had multiple falls. Any other questions on that for right now? Okay, so we're going to move on to another section, prior surgery, J2000. So J2000, the item rationale, it identifies whether the patient had a major surgery during the 100 days prior to admission. And recent history of major surgery can affect a patient's recovery, from everything from some people metabolizing anesthesia, can just really cause some issues with being able to process information, to potential complications from the surgery. So this is an important question. So we want to interview the patient if we can and review the patient's medical record to determine whether the patient had major surgery during the 100 days prior to admission. And when we say we interview the patient, what if the patient can't tell us? Then we can go to their family or their loved ones, their significant others, whatever term, someone who would know their history. And the idea is let's get as much information as we can to figure out whether that person had any major surgery in the last 100 days. So we have a question around this, and in this area, we're going to complete only at the time of admission. So we're doing this as one of those questions that are asked upon admission. We're going to code it as 0, no, if the patient did not have major surgery during the 100-day prior to admission, or we're going to code it yes, they did have major surgery. So this is a yes, no, or there is an 8 here, and the 8 would say we don't know. We are unable to determine whether they had surgery or not. So it gives you the opportunity to code that as 8 if you're unable to get the information. So let's look at what we're calling a definition of major surgery. So generally, major surgery refers to a procedure requiring general anesthesia. In addition, major surgery usually carries some degree of risk to the patient's life or the potential for severe disability if something goes wrong with the surgery. A patient would be expected to stay at least 1 overnight in the acute care hospital. So these are the general guiding principles that you're going to use to determine whether someone had major surgery or not. So let's look at some scenarios here. So Mrs. T reported that she required surgical removal of a skin tag from her neck a month and a half ago. And that's the only procedure in the outpatient setting. And Mrs. T reported that she had no other surgeries in the past 100 days. So we've had a skin tag removed. So what do we think about that? How would you code that? Right, 0. Good. Very good. Right, so that was an easy one, okay? They had a skin tag, and so it's not a major surgery. So she didn't have anesthesia. She probably just a little local anesthesia, if anything, and she had no major complications, right? All right, so we're way ahead of time on this section, but let's kind of pull it together. So let's talk in summary. So in J 1750, we're talking about the history of falls. J 2000, we're talking again on the admission assessment prior to surgery. These are all completed on admission only. Then items J 1800, any falls since admission, and J 1900 knows where the remember the 3 questions A, B, and C, are the number of falls since admission are only completed on the discharge assessment. And it's important to remember the definition of falls, especially that interrupted fall. So we went on to further define some falls: unintended change in position, coming to rest on the ground floor or onto the next lower surface. And I don't think anyone here has a problem with that definition, and I think that meets a kind of standard definition that you have. It may be witnessed, reported by the patient, observed by or identified when a patient is found on the floor or the ground. Not a result in overwhelming external force, meaning people are not going around pushing them down, so that wouldn't be it. And an intercepted fall occurs when the patient would have fallen if she or he had not caught him or herself, or would have had not been intercepted by another person. And so that person interceded on their behalf, and then were able to keep the fall from happening. Some of the questions that came up or the points of discussion is, what if someone is, a patient's walking down the hall, slips, grabs onto the side rail, railing in the hallway, rights themselves, but no one witnessed it. No one saw it, and they don't report it. What would you do? Any ideas? You can't do anything. You wouldn't know about it, right? Yeah, you wouldn't know about that. So you might find out about it if they ended up with a bruise, and then you were talking to the person, you say, well, gee, what happened? You know, you got this whole bruise on your shoulder. Yes, I was walking in the hallway, and this happened. Oh, okay, now I know about it. But that actually came up as a point of discussion. So if we don't know about it, we don't know about it. So it's hard to capture something that we don't know about. So let's talk about your action plan. So I think this is going to cause you to. This is an area where you definitely need to think about your action plan. What are you going to do when you go back to your facility? How are you going to train on this? These are some new interpretations, especially the intercepted fall. The idea of what is no injury, minor injury, and major injury, or injury, and then the next one being major injury. How are you going to train your staff? What kinds of tools, processes, and documentation do you already have in place? If you did a practice, could you go into a record and pull this information? If not, what else do you need to do differently in your organization? So these are some of the strategies that I'd like you to think about with your action plans. So the whole idea behind using the action plan is when you leave here today and you go back home to your facilities, you've got already a whole bunch of to-dos. You've kind of thought them through. And then there'll be more that you're going to add on to it as you go through. But so that's it for Section J, and we're way ahead of schedule. Probably because I couldn't answer the intercepted fault, that balance question for you. Do we have any other just general questions?
Yes, this is about reporting when a patient is working with a therapist in physical therapy or occupational therapy, and they're doing things in order to help them become more independent. And at the time, and as being supervised with their therapist, they lose their balance and they have that safety net of that therapist. Why are we having to consider those falls and increase the number of falls, and of what significance is it when the whole idea is to try and make your patients more independent? That's my question.
Yeah, thank you, and I don't disagree. And that may be the end result of the answer to that question, is it wouldn't be considered an intercepted fall. We need to go through the process and we'll get you that answer. But I think we hear you loud and clear on the concern and the question. Like I said, it was brought forward. It was brought forward, though, at a later point just before the training. So we just didn't have the time to vet it. And so, but we hear it from the therapist pretty clearly that you would like it to not be considered an intercepted fall. That is part of the therapeutic intervention. So again, if you could just be patient with us, we will get you an answer, but we do appreciate your insight and comments on that. Over here.
Thanks so much for your training. I wanted to clarify something discussed before, that details of a fall that would be used to answer J 1800 and 1900 can exist outside the medical record on incident reports and risk management solutions.
So I'm sorry, I missed the last piece. It can exist
So it would
outside
exist outside the medical record. So
Yes.
the medical record may have the patient fell, but all of the details of that event would be in an incident report or risk management
Yes.
solution separate from the medical
Yes.
record. So those details do not have to be in the medical record.
Correct.
Okay, thank you.
Yeah, they may be in the medical record, but they don't. There's no one going to turn around and say you have to put your incident logs or reports into your medical record. So yes, go ahead.
My question is about health conditions. With the definition of a major surgery, if you have an outpatient procedure requiring sedation that can, sometimes put risk to the patient's life, would you consider that? And I saw in there that you had added in this presentation that an overnight hospital stay, and I'm just wondering if you can add further clarification to the manual, and if it has to be an overnight hospital stay, or is it the sedation piece of it that determines what you count?
Yeah, and thank you very much for that. And so certainly put that down in writing. So very good. That will respond to that. These are kind of giving you some suggestions. It's usually, again, the idea of major surgery, not minor surgery. So, did they have general anesthesia? Are they staying overnight? You see where it's not just a procedure, but we're looking at rest. Now, one of the things that came up when we were talking about this and prepping for training is what happens if they open your brain and they, take part of your skull out and you have to stay awake, for that. Would that be considered major surgery? Well, if you're operating on my brain, I want to consider that major surgery. So, I think there's a little bit of clinical judgment that needs to be put into place, but I can appreciate it. We are going to be updating the manual. We'll be putting out frequently asked questions and responses, so hopefully maybe we can put some more clarity around that, those questions. I think you're next? Okay.
Yeah, when you're clarifying things, can you also please clarify on your definition here of a fall? You have an intercepted fall occurs when the patient would have fallen if he or she had not caught him or herself, had not been intercepted by another person. This is still considered a fall. Loss of balance does not always equate into a fall. So you can have a loss of balance that does not equate into a fall, correct? I just want that clarified.
So again, I guess what we would say is, so if someone's losing their balance and they self-correct, I think that was one of the questions that was asked before, we wouldn't consider that a fall unless they were like, doing the 3-step over to the, and they, kind of grab onto something to steady themselves versus they're starting to lean and they use their walker or whatever devices that they have to right themselves, then we wouldn't consider that a fall.
Because, I mean, there are many times that patients have loss of balance, but it would not necessarily equate into a fall. So as long as it's documented that it's not going to equate into a fall, then that would
I don't
not
want to get
be.
into the whole documentation piece of it. I think, some of the discussions that we had is, well, what if the CNA is walking the person to the bathroom and they have the gait belt on and they tend to lean and they can kind of right themselves, but we need to help them. And it gets into, you think about this as I think we need to get back to what is the intent, what were we trying to get out of this? And then the legacy of what this came out of the MDS 3.0 and what was the intent. So we'll get back to you on all of those types of questions.
Number one, thank you for this discourse. This is very important. Number two, along with what therapy is asserting, and I'm a therapist, and I can say that if we are training persons for mobility and functional mobility, et cetera, and we help them self-correct during therapy, I encourage CMS to consider this to not be a fall, but to be a skilled intervention. But that being said, I would like to include rehabilitation nursing, which is an extremely important part of the rehabilitation process to be considered in this discourse.
Okay.
Because if they continue to follow up with skilled intervention after hours when therapists are not there and continuing the rehab process, and the same scenario happens, whether or not we count that a fall, I think needs to be considered.
Yeah.
Number three, if CMS has any questions right now, I encourage them to ask. You've got a bunch of people in the same room. Thank you.
Thank you. Thank you. I appreciate the comments. Yes?
I just wanted to get some guidance on the whole concept of quality reporting. Currently, our facility really focuses on unassisted falls. There's no reason we can't continue to do that and say count unassisted falls and then count assisted and intercepted falls as a second measure.
As far as an internal quality measure?
As far as internal, right.
Oh, you can do whatever you want as an
Okay,
internal
that's
quality measure. Absolutely. Absolutely. No, I mean, I think that's great. And, because it may change a process, our system within your care system. So I think that would be really important to understand that. So that's great. Any other questions? Comments? Thoughts? All right. Well, we are done a few minutes early. I'm not sure who's... Oh, you are? Yeah. Okay. Gina is up next. Thank you very much. And Gina?